this doesn't ding. I need my ding. There it goes. Okay. Ooh, I feel jump ups. Alright, it's gonna be warm, huh? Okay, so first things first is gonna be vaginal canal. So we're going to talk about landmarks first. You see the bladder here. Full bladder helps because it's going to be the window to everything that you need to see. You have a retroverted uterus.
What does that mean?
It's pointed towards your back.
Oh.
There's nothing wrong with it. It's just how it sits.
Oh.
So the bladder is going to be your landmark here to find vaginal canal, cervix, everything. So find your bladder first. And that's going to be your window. And I'm angling very inferior. Like, you'll see how steep of an angle on the probe here to be able to get her vaginal canal. So this is uterus here, okay? So vaginal canal is going to be more inferior here, okay? So you're going to see probably like hyperechoic line or a hypocanal there. That's going to be your canal. Just lengthen it out as best you can. So you guys see the kind of bright white little stripe down the middle here?
Mm-hmm.
Okay, that's going to be part of like knowing you're straight with it. You want to see that line going right down there. And then next thing will be transverse. So you just turn your probe in trans and angle posteriorly. Now, I want you guys to recognize something so that you don't get confused. I'm angling back up. This is her cervix. So I'm going down. This is vaginal canal. If I go any further, can anybody tell me what this is?
Yes.
What is that? Can't hear you.
Ovary?
Nope. I'm inferior, going like way past her vaginal canal.
Uterus.
Nope.
No,
Uterus
it's
is going to be going
the
superiorly. It's her rectum. You are correct. We don't need to image that. Okay? So, when you've gone too far, that's what it's going to look like. That's her rectum. That is vaginal canal. You see the stripe right here? Okay. So then we're going to keep going. Aiming superior towards her head, and you're going to see cervix. So this is transverse cervix. Right here. Okay? Now I want to get it midline and behind the bladder. So now do you see how I've had to kind of move around? This rocking back and forth, that's going to bring you into the center of your screen. So once I've aimed up here, now I'm going to be in the cervix. And I'll tell you, her cervix, you've got these shadows coming down either side, the fornix on the side of the cervix, they create those shadows when you're in trance. So this is kind of like one of those little clues that you're in the right spot. And you're going to have this circular, like donut shape to the cervix. Okay? Now because she is retroverted, that means her uterus points towards her back. So to lengthen it out, you have to go to that organ. And her bowel is moving up here, creating those shadows. Okay? So right about here is going to be my midline uterus. So this is vaginal canal, long cervix, that central hyperechoic, and then leaning down into the endometrium, and this is the fundus of the uterus. So her uterus points posteriorly. That is why it's retroverted. If her cervix came up like this, and then her uterus bent back, that is retroflexed. And anti-flexed is where it comes up like this. That's the typical presentation. We're not going to say normal because her uterus is still normal. It's just how it's laying in her body, okay? So, external os leading into vaginal canal, cervix, internal os, endometrial canal. This whole structure is her uterus, and it's her uterus in midline. So I'm gonna do, there's no trace on here. Okay, I'm gonna use the cervix trace. Okay, no, never mind the fact that it says cervix, but I want you to see how you measure it when it's like that. So we'll go all the way to the edge here with the fundus, and you're tracing the endometrium. Everybody see that little central canal area? It's kind of like more hyperechoic than the rest of it, and out to the edge. That is the length of her uterus. Does everybody see that? Does everybody see how I got that? So what I have to do, it's not just a long and trans anymore. Okay, it's not straight up and down and trans. With your kidneys, you have to go to the organ, yes? Which means your probe's gonna be all kinds of wonky, but it's long on the organ. Same concept here. We're going to the organ. Also, don't forget to apply a little bit of pressure, because this is me not applying hardly any pressure at all. Do you guys see her uterus? Not really, right? A little bit of pressure, and now what do I see? I see what I need to see, right? Does that hurt? Uncomfortable? Okay. Don't be afraid to push, you guys. You're gonna have to. See, as the bowel gas moves, how much nicer it starts to look? Okay. And it's very possible that all this bowel has pushed her uterus that way. She clears her bowels, it might antiflex and go back that way. So the uterus can change its shape somewhat as you're scanning. I've been doing a vaginal scan and the uterus has gone from anteverted to retroverted as I'm scanning. So depending on how loose the ligaments are in there holding everything together, it can kind of move around a bit. All right, so when we're doing the uterus evaluations, I think you guys are just doing like a right to left. So these are your sweep images. And you can give me a right, a midline, a left. That's fine, as long as you show me you've evaluated it. But those of you that have been with me and watched me scan already, if we're doing a uterus evaluation from right to left, do I just want that, and then that, and then that, and that's it? No, give me a little bit more, okay? Show me that you've evaluated it. So give me that, and then give me that, and then give me a nice midline, and then give me a little bit more left, and then a little bit more left. You guys see how I did that? I didn't take 18 pictures, but I took a little bit more than 3, especially if your uterus is a little bit bigger, if there's something involved you need to demonstrate. So you'll do a right to left sweep, and with your trans, it's gonna be the same thing. We're doing a superior to inferior, but it's labeled lower uterine segment, body, and fundus, instead of like a superior, mid-inferior. So lower uterine segment is gonna be right up from that cervix. So transverse cervix, and we're just gonna go up, and this is that lower uterine segment here. I'm gonna fix this a little bit, because there we go. You guys see it? Where's my focal zones? Are they not changing? Okay. So once again, cervix, and aim up, that's lower uterine segment. In long, this is the area that we're looking at. Right here, okay? So if this, come on gas, I'm trying to do something here. All right, so this is cervix, this is lower uterine segment, this is body where it's at its widest, and then fundus is here, okay? So when we go in trans and do that, straight from the cervix up, that's lower uterine segment. I have to adjust a little bit. You doing okay? Mm-hmm. All right. Now where it's at its widest, where I would take my measurement, would be your body, and then all the way up and through, and then back, and that is the fundus. She got some bowel gas moving around here, so it's a little bit tricky, but can you guys see?
Yeah.
Just that little piece there. So fundus. Sorry. Body. That's a good, see the gas moving? It's so much better. So body would be where you take your width measurement here at its widest, okay? And then lower uterine segment would be right before we get back into the cervix, and then there's cervix, okay? Any questions so far? No. All right, so now, okay, so endometrium, this is important. You can get the endometrium in long or trans, wherever you can see it the best. Depending on how someone's uterus is laid, long is not gonna be the best view necessarily. So I can see her endometrium, but I'm also getting shadows down off the edge of that endometrial canal. There's a little shadow coming down here. So I could measure this, but it won't necessarily be the most accurate because I'm not seeing those margins super clear. So I can either angle and move around, try and wait for that gas to move, because you want to get it at its widest, closest to the fundus. So kind of squeaked it in here. But we're talking outer to outer on this echogenic canal. That's what's going to stand out to you. It's going to be brighter. So we got 0.84 on that. If I go in trans, because she's retroverted, I don't know if this is going to work as good, but we'll try. When you're retroverted, getting transverse endo is a little bit hard because what you end up seeing is just where it splits at the cornea. You guys see what I'm talking about when I say, see how it splays out like that?
Yeah.
Okay, because that's like coming from the tubes from the cornea. So I can't do an AP measurement right there because the borders aren't clear, right? So if you can get a clear border in trans and you can see it enough to get a measurement, that's fine. Wherever you can see it the best.
For a typical positioned uterus, what would it look like? Just a line across?
So depending on what stage in their cycle that they're at, you may see the 3 lines. So you may get like the outer hyperechoic lines and then the inner hyperechoic stripe, depending on what stage of the cycle they're in. But it should stand out to you as clear in trans as it does in long. And so you can mark those borders. Just make sure you can see those borders clearly. A lot of times we've seen me change it to a tint map. Anybody who's watched me scan in clinicals, that tint map will change what your eyes are seeing. Just for the moment, just for something that's subtle, that's got diffuse margin, something that doesn't stand out super crisp and clear to you, and you changed your frequencies and you changed your gain and all that. I like to go to the sepia setting. Who now can tell me they can clearly see those borders? Yeah? I mean, that's not really the best image to look at, but they're clearly standing out to me in this better than the gray. So a lot of times when I'm doing like fibroids or endometrium, something where the margins are not super sharp and defined, I'll use this setting to kind of help give my eyes a different shade to focus, and it brings those margins out clearer. So you can use that if you want. You just go back to Jen to reset everything. All right, so is everybody clear on endometrium? That is going to take some practice, just like the ovaries. I don't know if I'm going to be able to do ovaries in her. All right, so we'll just look together. My best suggestion when you're looking for ovaries is to start with your transverse uterus at the fundus and then scan down until you see those tubes branch off. You might not be able to see the tubes exactly themselves, but you can see the area that it's coming off at. So it kind of gives you more of a target zone to search instead of just scanning all over the whole pelvis, being like, ovary, reveal yourself. Like, it's harder that way, trust me. So for her fundus is pointed down. So I'm gonna start from the cervix and work my way up. You see anything interesting in this picture? Ovaries! Here and here. See how that comes off right there? That's a tube. So that's gonna lead me to an ovary. This ovary looks like it's a little more snug with the uterus, but that's exactly how you're gonna find them. And then now I see, okay, well here's the right. I'm gonna try and turn on it. No gas. Okay, so it's got a little bow gas going on. But you guys see the ovary?
Yes.
Everybody see it? Who does not see it? No shame if you don't see it. Ovaries are hard.
These are hard.
Ovaries are hella hard. Just so y'all know, like.
Can you point out the tubing? Can you see it?
Somewhat. Right here.
Okay, that's why I just was wondering if I was looking at that.
So this right here is gonna be the ovary. See those little follicles on it? Use that to find it. Don't just start here and go, I don't see it, because you'll never find it. Unless it's just PCOS and they're just right there. So use that technique. Come up. This ovary is sitting here. I'm just gonna angle. I didn't move. I didn't slide. I literally just angled because I'm using that bladder. I want that bladder to help me see that ovary better. Okay? See, as I'm coming up, did y'all see how it came off right there? Watch right here. I'm angling up towards the fundus. And then that's an ovary right here. Everybody see it? Follicles? We agree, ovary, yes?
Yes.
Now, is this long or is this trans? looks like trans, right? But I don't know that until I kind of move around on it. So once you find it, look at that. Now do we see how much bigger it is? Sorry, love, I know I'm really pushing on you. Gas, get out of here. Okay. So now I've kind of found it, and then I'm doing this number. Okay? I'm not this and this because I need to see the shape. I need to see where it lengthens out at because it's laying in there however which way it wants. There is no rhyme or reason to ovaries. They do what they want. So when I'm looking for it in long, I'm not just going like this. It's this. Like think about, anybody play video games, like a joystick, right? You're constantly moving that joystick around until you get what you're looking for. This is long ovary. From here to here. Little almond shape. I can see the follicles. I can see my borders. There's gas right here. But everybody understand? What I was seeing earlier when I found it was more like transverse ovary. Where'd you go? The gas has moved in, and now we have to do a transvaginal. I'm just kidding. Just kidding. We're not going to do that. But do you guys see how fast that can happen? The gas moving in your way? But you got to find a way to get around it. So I am like very weirdly, sharply angled at stuff. Do you guys see this? I'm not just staying like here. Like you're gonna have to really work those angles when you're looking to get around gas, okay? Because this is lower intestines that is now our obstacle, not up here. And your ovaries lost
Everyone
rest
should have
forever.
to take Beano before they have an ultrasound.
My gosh. Okay, so here it moves. I found it. Yay! So there we've got transverse ovary. Nice circular, can see my margins, okay? Biggest thing is you want to see those borders and lengthen it out. All right, what else? Adnexus, I think. Do we do, yep. Adnexus.
Color.
Yes. I mean, yeah, read your protocol. But like, you guys know those things. I'm just trying to give you techniques. Y'all are getting so far advanced in certain things that I don't have to detail out every little step of the way for you guys now, right? Okay. Okay, so adnexes are pretty simple. Doing a long and trans with and without color in long. Yeah, show iliacs color. Okay, so your iliacs sit, there we go. So this is midline here. The adnexa is the space between iliacs and uterus. That is what that space is defined as. So when we're evaluating the adnexa, the ovary lives there, bowels live there. We need to make sure no other things live there. No masses are hanging out, no cysts, no fluid collections, nothing like that. So I'm gonna go all the way out, and these are her iliacs. This is her hip bone. So I have gone as far as we can go, okay? This is her hip bone right here. So I'm gonna angle up here, but I don't wanna just get this. You see what I'm saying? Like just this iliac here and then bone and space. What I'm evaluating is the adnexa, the space between uterus, uterus and iliacs. So does everybody understand what I say? Like, don't just take a picture of just the iliacs. Like, you need to evaluate that space. So you found your uterus, we're angling out, and there's iliacs. They should be kind of top left of your screen. You see that? So what I'm showing is adnexal space, but what I'm showing you with this is I'm in that adnexal space because I can see iliacs. Does that make sense to everybody? Okay, so that's why we have you do it with and without color.
So with 3 or like how many images would be acceptable to get the full adnexa?
It is just a trans and then a long with color. So 3 pictures.
Okay.
A trans, a long, and a long with color. Yep. Just making sure I don't have it written down anywhere else that's weird. So this says right adnexa trans. That should be under the long, shouldn't it? Sweep from uterus to lateral adnexa. We need to amend that because that's spelled wrong. Yeah, it's really just like 3 or 4 images. You're showing me the adnexal space in trans and long and a color representative picture. Okay? Same thing, come over here. This is going to be left adnexa, iliacs, hip bone, and uterus. So I'm just going to angle out, just like that. It's a pretty simple picture, honestly. And then you just throw color on the iliacs. Anybody else have a full bladder? Who did not pee?
But you won't be able to see anything.
Haven't we already scanned your wonky uterus?
Haley.
My wonky uterus. No, you can't see my uterus.
Your bladder's full? Cool. Let me just see. Thank you for your service, ma'am.
You're welcome.
It was actually really great that you have a retrograde uterus because it's something that it's very, very common. So they need to learn what that looks like too. So appreciate your services. No, this wasn't in your contract, but still, we thank you.
Well, now I know.
Now you know. Now you know that when you're here, you are bound to be voluntold at some point. But I'll let you get back to it. Thank you, ma'am. We're gonna look at one more real quick, and then we'll let you guys go. I just want to see what Haley's looks like. Y'all don't want to get my little shriveled up raisins of ovaries. Been weighed down by hormone suppression for 15 years. Dr. She had a hard time finding my ovaries, you guys. Okay? Okay? They just cannot be found. Right, and tuck. Excellent. Yeah, there you go. Sorry, I pinched you. No, it's good. Okay. Let's see. I'm just gonna line everybody up. What does your uterus look like? What does your uterus look like? We'll find out, won't we? Warm. Let me go back. Right. Oh, that's pretty good. You're retrograded too. You're not. All right, so on Miss Haley, Miss Haley, excuse me, her bladder's super full. That's what we need. Vaginal canal, everybody see?
Mm-hmm.
Very, very nice. Yes? That little white stripe down the middle, that's your long vaginal canal. That's transvaginal canal. That is long cervix. Now, with her bladder being super full, it is great for us. But do you guys see how?
Full bladder.
Isn't it gorgeous?
Wow.
And it's a gorgeous uterus. So here's how I have to. I mean, you're gorgeous uterus too. It was just gas laced. Okay. All right. So for the bladder being super full, it's good, but you have to use it to your advantage. Otherwise, it will work against you with the shadows that come off of the edge of it. So do you guys see how I like rotated it to where the uterus is like nice midline and I have all this bladder over the top of it? So everything has this really great attenuation, right? I can see the whole shape of her uterus. I can see look how gorgeous the borders are. Got a little fluid there, but that's fine.
Like a week.
Yeah, okay, makes sense. So cervix is here. Kind of got vaginal canal out of the picture a little bit when I tilted it. But do you guys see the cervix?
Yes.
Yes? Outside to the inside. Outer margins. Everybody see? Okay. I didn't hear a lot of yeses, so we're going to do this again. Now, if I just stayed here and went like this, how great is that? It's not terrible, but can we do better? We can always do better. So what I'm doing is really sharply like heel toeing it, and look at all of the bladder now I put over the uterus. And I can go all the way to the right and see her nice little ovulating ovary there. And then sweep through, a little free fluid in the cul-de-sac, that's fine. And see her other little gorgeous ovary also as a follicle over here. Do you guys see how effortless that was?
Mm-hmm.
Saw everything.
Yeah, that's not right. That's not right.
This is not typical in the clinical setting, just so you know. Just ask Bailey and Brandy from yesterday. It was awful. But this is what we're gonna need for you guys to learn, to get familiar with your structure, so when you get the things that are super tough, you can be like, no, I know how to find this. I know how to make this look okay. So again, all the way to the right, give me this one, a good midline for measurement, a little bit left, all the way left. That's your sweep images. In trans, see, now, Alyssa, this is what you were asking about transverse endometrium, right?
Mhm.
So she has the 3 lines right now at a stage that she's at, so you can see that. What I'm gonna have to do, to see how thicker it looks when I come from this direction than it does when I'm here, and it's even. So if I can see the borders nice and even here, I'm not gonna bother to do a trans image, okay? I wanna get this picture because it is the clearest and you wanna get it at its thickest. So I'm gonna measure here to here, the widest, up towards the fundus, okay? Now that's 1.6. When you're doing it trans, the trick is just to get it even. Does that make sense? So, about like that, right? Let's see what we measure here. Little less, not too far off, but comparable. Where'd you go? But comparable. So, if you cannot see it in the long as well as you can with her, try the trans, but do you see how clear the borders are and how it's even across for the most part? That's what your criteria is when you do a transverse endometrium. Okay? When you're doing long endometrium, you just want to lengthen it out as best as you can and get that thickest portion there. Okay? So I'll come out to the side, and now look how I can make it all connect. Bring the cervix in. Does everybody see it? And this is just a constant little twisting and tweaking. It's not true long, right? That's long on her uterus. Let's see her gorgeous ovaries. All right. Any questions on the measurements or landmarks or anything so far? Everything making sense to everybody?
Is that thick? Like, is that too thick?
Well, no, if they're not, not if you're about to have it. It's gonna get real thick and then it'll shed. That's why it has this kind of hetero appearance right here. That's probably blood products already starting to shed, and it just hasn't fully gone into that cycle yet. So for her ovaries, this is another thing you can kind of tell that you're about to start your cycle. This little fluid bit down here from ovulating. Did you have ovulation pains recently? Little crampy bits? Okay, that's what that is. This is your dominant follicle. You're ovulating from that ovary. So, does everybody see her ovary?
Yes.
Yeah, right? Right? All the ones that were with me, yes, finally, I see an ovary. So in trans, had I not been able to see them so well with my sweeps, we'll just go into trans and I'll show you kind of that trick. So, it doesn't even work with you because you can already see them. But y'all get my point, right? Fundus, come down and you can see a little tube scoot off here and then an ovary. Same thing on this other side. This ovary is a little bit more tucked in. So her tube actually is here and it comes around and down onto the ovary here. Do y'all see that? Right here. And then this side, there's that tube and it comes up and kind of wraps. So they kind of you watch football players and they tuck that ball under like that. That's what they're doing with the ovary. It's tucked. So you can see the tube sometimes, but you'll always be able to at least see a point of reference to get to the area where the ovaries are. Does everybody make sense of that? Yeah. And again, just gonna turn until it looks long. I'm twisting on it. So now I'm kind of getting more trans. And I'm going to use that bladder, so I'm going to actually come from the left and angle towards the right. And now you can see all of that ovary, and you can figure out what's long and what's trans. That looks like long to me. Everybody agree? Just from one end to the other. That's your length measurement. Do the same thing for the other ovary. And when you're doing your ovary images, it says long and trans, measure length in AP, color, and pulse wave. So you are doing a Doppler on the ovaries. But the protocol seems like it only asks for one picture, one long, one trans. I would appreciate it if you gave me a little bit more than just one image. Just show me that you evaluated it. I can give just this one picture and be there's the ovary, done. But if I show you this picture, do you know that that's there from that image? No. So if that's there, show me that. Document that, please. Okay? Show me this, this, this. That's it. 3 little pictures, ovary's done. And if they have a tiny ovary, it's 2 pictures. She's a little bit plumper ovaries. So when we're doing the transverse images, you don't have to label them superior, mid, inferior, but show me, hey, that's what's hanging out at the superior, but here's mid for a measurement, and then there's the rest of it. Everybody understand that? Cool. When you're documenting, you guys have been in clinicals long enough. I'm really thinking you know how to document pathology by now. So, give me a long and trans with measure, throw a color on it. If you see something like a cyst or a really dominant follicle. And the Doppler is super important. Biggest thing is to make sure you're not getting the tube. That's going to be a higher velocity and a higher resistance. So you'll know when you're in tube and when you're in ovary. Ovary is going to have low resistive flow because we want constant perfusion to this important organ, yes? That's venous flow. I'm going to find an artery. Oh, I think that's tube. I'm going to show you what it says. That's tube. That is tube. Just there we go. You guys see that? Okay. I'm gonna find one in the ovary so I can show you something to compare it to. I can hear you. Oh, this touch screen. Oh, too much. Too much. Bear with me, guys. Sorry. Machine is rebelling against me. Okay. This is gonna work. Turn the filter down. See all these vessels kind of around it? Leading from, most especially that one, leading from the uterus. So that one right there, do y'all see that? That's part of the tube, because that tube comes up right here and wraps around. So make sure when you're getting it in the ovary, not in the tube. Do y'all see how I kind of went from like tube and now full into ovary? Alright, there it is. Do y'all see that bottom one? It's a little bit lower velocity here. And it's okay if it's on the bottom because those vessels kind of like are spidering all out into the organ. So you don't need an angle. You don't need to change and flip-flop and invert anything. It's fine if you leave it like this. But y'all saw the difference in that really sharp up peak or upstroke in the velocity when I got the tube, and now this is a little bit lower and lower resistance, so our peak and our diastolic are a little closer together. So that's going to tell you the difference between a tube and the ovary. Ovary is low resistive. That tube might be a little bit more higher resistive, so you'll know the difference, especially if that peak like shoots way up and you're like, holy crap, that's like really high velocity. Like that's really not typical for an ovary. You want to keep it between 20 and 40 for the most part. It's not saying that everybody's going to be that, but you guys understand how to do Doppler evaluations now, right? And how to measure pulse waves, how to adjust your scale, all that. Same thing applies when we're doing the Doppler on the ovaries. So all you have to do is color and a pulse wave and measure the pulse wave. And you can get that in either long or trans for the pulse wave. Okay? Any questions? So show me a color with the pulse wave and the measurement. Measure the ovary itself. Thank you, ma'am. Everybody's going to scan you now.